Thank you, Hein, for the welcome. Sorry I'm late. I've just had to quickly run across from an interview with 9 to Noon, which thankfully went well, so that's good. So as we know, some of these problems aren't new. Hein's mentioned the presenteeism, the working through illness, which was the topic of the first research I undertook 2 years ago now. 88% of those who responded to the survey reported regularly working through illness. And unfortunately, little has changed, and the burnout research really emphasised the way in which staff across New Zealand's public health system, and in particular you all, are regularly putting your health and well-being on the line in order to continue providing that crucial care for your patients. So the focus of today's presentation is again not a happy topic, but it is a really important topic, and it's the issue of workplace bullying. Now, it's not a new topic. We've known for some time now that there is a problem in healthcare, and as Victoria outlined yesterday, 2 years ago, the findings from the Royal Australasian College of Surgeons were really shocking. I don't think you can call it anything else. More recently, we had the research by the RDA as well, looking at the rate at which resident medical officers were being bullied, and unfortunately, it wasn't a good story for us because the perpetrators or the perpetrators of that negative behaviour were largely found to be those in senior positions. And in the August of this year, we have the findings from the Australasian College of Emergency Medicine, which also found very high rates of bullying for those working in emergency departments. Now, the ASIM research was interesting, and as they note in the report, doctors working in emergency departments are under huge amounts of stress. Both the survey I'm presenting today and the ASIM survey were also conducted over winter, when we know that emergency departments traditionally face the highest loads in terms of patients. So the other thing to note is that the prevalence of bullying alone as a facet of the broader discrimination and harassment behaviours was found to be 34.5% in the ASIM study. So 34.5% of those who responded said that they'd been bullied. And methodological differences aside, that prevalence rate is significantly lower than what we've found in our study for those working in emergency medicine, as I'll go on to explain. So we know that bullying is a really complex problem. It's got multiple antecedents. And in healthcare contexts, the research does acknowledge that bullying flourishes when you're in stressful, unsupportive working conditions. And I think whilst these stressful working environments are not an excuse, it's important to acknowledge what that kind of brings to the picture. And I really like this schematic here, because this, to me, encapsulates the important influence of these three different spheres of influence, if you like, on the antecedents of bullying. If you're working in a work environment where you're poorly resourced, where you've got staffing shortages, where people are routinely having to work really long hours, then that is going to, if you like, start shaping the culture that exists in that department, where snippy words or the brusque greeting or the lack of greeting in the morning can become normalised over time, as that's just the way we are. And unfortunately, you may have the person with the personality disorder in your workplace as well. And having the odd individual who perhaps, as Victoria nicely and euphemistically put it, is lacking in insight, can also feed back to shape and exacerbate the negative aspects of that work environment, and crucially the culture that emerges. So the antecedents of bullying are complex, they're iterative, they feed into each other, and they're all really important to acknowledge. So for the research that we conducted, as with all our research, we followed international best practice, and we defined bullying as follows. It's repeated and persistent negative acts towards one or more individuals. It can be interpersonal aggression, or it can be hostile antisocial behaviour. The key thing here is that bullying is systematic and it's repeated over time. It's not just a one-off. And importantly, the perception of the victim is the defining factor. You may not know that what you're doing is being received by somebody else in such a negative way. You might not know that that person is feeling victimised as a consequence of their interactions with you. And again, this is why it's really important to shine a light on this problem so that we can all learn how to improve. And I find actually looking at the raft of different behaviours that constitute bullying, and these are the sort of categories of bullying that we used in our research, is really helpful because, again, they show the breadth of behaviours. So bullying is not just the threats of violence, the fist being slammed down on the table in a meeting and so on, or being shouted at. But bullying is also things like being ignored in meetings or having your opinions consistently ignored over time. It's having your work micromanaged or excessively monitored. It's also the interpersonal things, being ignored repeatedly by the same workmate, being the subject of gossip or rumours behind your back, which the other people may not think anything of really, but to you that can be hugely damaging. It's also the allegations, the professional allegations, which can be so damaging in medical contexts, or being given, silly tasks or trivial tasks to do, which you find really demeaning if that happens over time. So bullying can be this mixture of both overt and really covert behaviours. It can be subtle and devious, but again, most importantly, it has to be repeated and persistent, and it's what that behaviour feels like to the victim that is crucial in defining whether or not it's bullying. I like the metaphor of the feather to illustrate this, because if you're given a snub one day at work, if that's just a one-off, you can brush it off. It doesn't weigh heavily on you. But if that snub is repeated and it's persistent, then that single feather can turn into a mountain of feathers, and that can weigh really heavily on you if that's been happening for a long period of time. So even the smallest negative act can build up over time, and it shouldn't be ignored. So in the research that I'm presenting today, as Heinz stated, we wanted to shine a light on what's going on for the senior medical workforce. There have been some studies overseas which have looked at the prevalence of bullying in senior doctors exclusively, but they've tended to be restricted to those working in particular specialties or in particular hospitals. So this is the first study to estimate the prevalence of bullying in the senior medical workforce across a country and across a variety of specialties and workplaces. Secondly, we wanted to look at, as we often do, to see whether there are any patterns according to demographic variables. It's really important to understand this because it helps inform our industrial activities as well as suggesting avenues for further research. And we also wanted to look at the consequences of bullying, how many people are reporting it, and what are the barriers. Now, I left this one to last because this in some ways is the most crucial. We know from the research, as I've already outlined, that the antecedents of bullying are many and complex, and it was really important for us to try and get some way to measure these factors. So we looked at the levels of workplace demands. Again, we used a validated tool to do this, and we also looked at the levels of peer, and we defined it as non-clinical managerial support to talk to, not just your clinical leaders, but actually explicitly your managers, your non-clinical managers, the people in HR, that type of thing, how well supported you are from them. We used the Negative Acts questionnaire as the backbone of this research, and this is, again, it's best practice. It was developed by the Bergen Bullying Research Group, And it's a really useful tool because it provides a so-called objective measure of bullying. It's a 22-item questionnaire which doesn't use the B word. So it describes a wide range of behaviours, from work-related behaviours to personal-related behaviours to the intimidating and physically aggressive behaviours. And you're scored as a consequence of this. So it's deemed to be a really robust and objective way of measuring bullying. And the other useful thing is that it is followed by a single item question which asks you, on the basis of the same definition I provided before, whether or not you feel that you've been bullied yourself, or whether you think that you've witnessed that behaviour being meted out to your colleagues. So we've got basically three measures of bullying in this research, which is a really robust way of doing it. So what did we find? Well, we had a 40.8% response rate. Now, some of you might think that's a bit low. It's certainly lower than the 62% response rate that we got for our workforce intentions survey, but actually I was really stoked by this. As Victoria said, doctors are not the best at returning surveys, but also when you're researching a sensitive topic like bullying, you do have a lot of people who don't want to participate for a variety of reasons. And I think the question of responder bias is one that we will always be queried. But in this instance, I don't know if we can say that it goes one way or another. Because I had a number of people email me and say, Charlie, I don't feel comfortable in participating in your survey, even though you've reassured me that it's anonymous, because I have been bullied and I'm really fearful of being identified. And we do ask for a wide range of demographic factors to be given in our surveys, and so I can understand that. So what I asked those people to do was to send me in their comments, which I could use for qualitative research, but they didn't actually participate in this study. So I would say that we can't say categorically that the responder bias goes one way or another. As with the majority of our research and the majority of our membership, the majority are New Zealand trained men and Pākehā. So the Negative Acts questionnaire, the NAQR, we analysed it by looking at the prevalence of experiencing at least one negative behaviour, and perhaps unsurprisingly, only 7% had not experienced any of the behaviours listed. So we're not saying that bullying prevalence is 93%. We apply the layman's criteria, which again is a robust way of ascertaining bullying prevalence, to find that as experiencing at least one negative act on at least a weekly basis, and people experience many more than that. But we would say that around 38%, so over a third of our membership, we're scoring as being bullied according to the negative acts. For our other two measures, the self-report measure, we took all affirmative responses as being indicative of bullying. And the interesting thing here is that you can see the percentages are almost identical. 37%, 38%. It's not unusual for people to not admit or concede that they'd been bullied, partly because perhaps they don't recognise what actually constitutes bullying behaviours. So it's really useful to have the two measures. And a significantly higher proportion who said that they had witnessed bullying in their colleagues, over 2/3. And again, that disparity is not unusual. It's consistent with the international literature, where people are either better able to recognise colleagues experiencing negative behaviours than recognising that they themselves might have been a victim. I'm not going to go into all the demographic detail today. There are copies of the full report available either on our website or outside, and you will also be receiving a copy in your December specialist pack for some happy Christmas reading. But I just want to touch on a few of the key findings today. We found that there were significant differences when we looked at the average negative acts score by medical specialty. And we found that those working in emergency medicine, general surgery, and what we grouped together to define as specialist surgery other were the top three highest average scores. When we actually look at the proportion, we found that those in emergency medicine over half had experienced at least one negative act on a weekly or daily basis. So if we compare that, methodological differences aside, to the findings from the ASIM report, that's quite a difference. We also found a significant difference in the average score by place of work. And I'm sure Hein's not the problem at Tairāwhiti.
You never know.
And we also have to recognise that there were low numbers of respondents from some of our smaller DHBs, which is why it's always useful to have the error bars in there. Thanks to Jeff Shaw for that reminder. But we can also see some of our bigger DHBs up there: Southern, Hutt Valley, Waikato. And that's an interesting thing. You know, Catherine Ryan on 9 to Noon said to me, well, is there a pattern there? I don't think there is. But the only thing I could kind of scramble around to say is that perhaps when you are working in some of the smaller DHBs and you do have perhaps one or two unpleasant people working in a department, the kind of ripple effects from that can be felt more keenly when you perhaps don't have such a big buffer. So this is the self-report data, and again, there are significant differences. And so the green bars there are the people who reported no bullying, the yellow are the people who reported bullying to some degree, and the red are those who reported experiencing bullying on a weekly or daily basis. And again, this is interesting. If we look at the red bar alone, you can actually see that cardiology is up there. And I was chatting to a cardiologist yesterday, where is he? There he is, as to why this might be, and he wasn't surprised. But also high up there, which perhaps is more interesting, is rural hospital medicine. Respiratory medicine being quite high overall. So some quite challenging patterns here, which probably deserve further interrogation. And in terms of the witnessing of bullying, again, really strongly significant differences by specialty. We see that those working in this pooled group of specialist surgery other had overall the highest rates of witnessing bullying. But also dentistry was up there, and that's curious. I don't know why. I'd be really interested to explore some of this a bit further. Anaesthesia, emergency medicine, palliative medicine, they all had really high rates of witnessing bullying on a weekly or daily basis. So some trends there that probably deserve further interrogation and exploring. Now, I mentioned before that we looked at these other three factors: the level of work demands, the level of peer support, and the level of non-clinical managerial support, which is a good mouthful. But unlike Elsa Clark, I'm sure you know what we mean by that final category. I'll explain that later. This graph here is actually the brainchild of Murray, who likes sort of visual ways of displaying trends and data. And so what we did here is we cut the bullying prevalence as measured by applying the layman's criteria to the negative acts score, and cut it into, and then we also cut the demands, the peer support and the non-clinical managerial support to either low, average or high. And I need to acknowledge the work of Chris Frampton here from the University of Otago, because he does all our stats. And what you can see here is that when peer support is low, you have the highest prevalence of bullying, so nearly, probably around 75% prevalence of bullying. And when work demands are low, you have the lowest prevalence of bullying. So the green bar is like an inverse scale, if you like. Now, when your support from your peers and your support from your non-clinical managers are high, which is the far end, then your bullying prevalence is also really low. And similarly, when your work demands are high, then that also has a strong effect on the prevalence of bullying. So it's a really interesting way in which we can kind of explore the impact of these broader factors on bullying. And it's really useful politically, I guess, to have the ability to speak to the fact that bullying is certainly associated with these wider factors. So we asked those who had experienced bullying and witnessed bullying to say who the main perpetrators were. Doesn't make for happy reading, unfortunately. So the majority of the bullying witnessed and reported was from other senior doctors and dentists, so it's peer-to-peer bullying. But what I found interesting here is that for those who self-reported bullying, non-clinical managers were the second largest, if you like, category of perpetrator. And for those witnessing bullying, the second highest or largest category of perpetrator were nursing staff. Unfortunately, clinical leaders, which we defined as a separate category, were also regularly cited as the bullies for those who reported it. But witnessing, patients really high up there too, patients and their families. And particularly for those working in some of the really challenging specialties like psychiatry and emergency medicine, it makes me wonder if some of the bullying received is not only from peers, but it's also from these other sources. We asked respondents who said they'd been bullied, self-reported, whether they had reported the behaviour. And again, I find this a really depressing graph. Only a third had reported that behaviour, and really importantly, we asked them why. The main reason for not reporting the behaviour was feeling that they wouldn't be supported. And the second reason was they thought that reporting it would make the situation worse. Now, we had a whole category of people who put other reasons, and I asked them to give comments to explain that, and again, that makes a really interesting reading. A number of people, and this is in the full report, they said, there's just no point in reporting it because the behaviour is so normalised, nothing will ever change. And other people said, there's just no point. So it's this kind of sense of it was such a big issue and so ingrained and so normalised that nothing would ever change. Very few said, well, actually the behaviour's stopped. So that's one positive, I guess. Of the 30% who had reported, we asked them what the outcome was. And unfortunately, very few noted that the behaviour had stopped as a consequence. 23, so just over around 12% of those who reported said that the behaviour stopped as a consequence of the issue being resolved. But unfortunately, for over a third, the issue never got addressed and the behaviour continued. So, I think what we can see from this, and also what we've heard from Victoria's presentation yesterday, is that bullying matters, and it matters for a whole host of reasons. Just to summarise some of the reasons that came out in the research, and also from what we know from the wider literature, people who are bullied experience poor health. They're more likely to have sickness absence, to experience significant levels of stress and anxiety. They're more likely to suffer depression. There's been some really interesting research from Kivamaki on this particular point. And they're also more likely to make a mistake at work. So there's a really pointy edge to this, beyond the kind of personal impact. Some of these other things, people who are bullied are less likely to show initiative at work. And as a consequence, clinical skills can decline. There's less willingness to innovate. You're far less likely to be motivated and your productivity will decline. And overall, your confidence in both yourself as an individual and as a clinician is likely to go downwards as well. So I just want to share some of the ways in which bullying matters in your words, in the comments that people left. And this comment really sums up some of those factors. This doctor notes, I've lost confidence in myself as a doctor and as a person. I'm very anxious and I'm less patient with my children because I feel so stressed. It feels like being trapped in an abusive relationship. I mean, that to me is just such a harrowing way of framing what it feels like. And crucially, they say, I see patient care being compromised. The quality of our service is eroded and I feel ethically compromised every day. Others note that bullying leads to self-doubt and second-guessing. They say it's difficult as the SMO to call it out because it is perceived as a sign of weakness if you're not able to cope with being bullied. Therefore, a lot of us put up with it, especially in a system where we're overworked with unrealistic schedules and no hope of making an improvement. And this, to me, really sums up the impact that the broader kind of structural factors of poor resourcing and stress can have, and how that can feed into a culture. And this person here really emphasising the way in which bullying can compromise patient-centred care. If you're receiving aggressive behaviour from another SMO, it makes you reluctant to engage a second time. You just want to back off. And then you can have a delay or a wrong decision to discharge a patient. And this person notes that having felt bullied, they are just pulling back and doing the bare minimum. They're kind of checked out in a way. They've tried to bring the behaviour to the attention of managers, but it's made no difference, and they feel that patient health is at risk. So where to next? Well, it's not as if we haven't been doing anything about this. Since the RACS report was released, there has been I struggle to keep up with the name changes, but I think it's currently called the Professional Behaviours Task Force, which Lloyd now sits on. And we've been doing a lot of work industrially for a long time now to assist our members, both who've been accused of bullying and also those who have suffered from bullying. And we've got a wonderful bullying standpoint, which is also in the process of being updated to kind of reflect some of this research. And that will also be sent out with your December specialist to perhaps try and provide a counterpoint to the health dialogue of doom. So I think these challenges sort of throw up challenges to all of us. And I think the way in which to address this has to be across all levels of the health sector, right from the government, who have to take responsibility for a lot of this because of the resourcing issues that we've experienced for so long now. Some of these things won't have clear answers, but we certainly have some suggestions as to what could be done better. And I really enjoyed Victoria's outline of the Evolve process yesterday, which is very similar to the thing that we've been advocating for, which is the Cognitive Institute's Vanderbilt graduated process. And as Victoria says, often all you need to do is to have somebody who's been given the appropriate training to go and tap that person on the shoulder and say, hey, should we go and have a coffee to have a chat about this? And apparently 80% of bullying complaints are readily resolved in this manner. And I think the important point to note here is that not all of our members are bullies. There are people out there who are doing a really good job and have really good interpersonal skills and know how to give fair criticism in a constructive and respectful way. And as Victoria said yesterday, we actually need to celebrate the good examples and the good exemplars of positive behaviour. But I think the fact that so few of the people who have been bullied report it is a real worry, because things won't change unless we make it safe for that to happen. And to that end, we've always emphasised the importance of fair, just process to make sure that everybody involved gets a fair hearing, so that it doesn't sort of escalate right up to the top of the triangle without fair and just process being adhered to. So I'll end on this slide. I said, how am I going to finish this to Angela? And she said, put a picture of Hein up. Now, I don't have a picture of Hein, but I thought this one you could pretend it's Hein, sitting in the corner in his scrubs, even though he's not a surgeon, having just read the health dialogue, thinking, oh, shit, where to now? But I will use Hein's words, because I think it sums it up really nicely. He says, bullying is not a diagnosis, it is a symptom. And it's a symptom that we have to see alongside all the other trends that we know, the burnout, the presenteeism, the intentions to leave because of poor job satisfaction, those things. They paint a picture. And this research into the bullying is another really important part of that puzzle. But we have to see them as all interconnected. They don't happen in isolation. So it is symptomatic of the health system that we know has been groaning for some time and does have these systematic problems. So I'll leave it there. These are some of the references. They're all in the health dialogue as well, but yeah, I welcome questions. Thank you.
Thank you very much, Charlotte. Lisa Dawson, Oncology Northland. With the graphs that show the red, the yellow bars for bullying, maybe I missed it, but would it be good to divide that up in the same way so you can see what is workplace bullying from colleagues and what is bullying from patients? Because that might shed a little bit more light on the behaviour in departments that need addressing.
Yep.
They're almost like two separate works of changing the culture in terms of changing what we'll accept from patients and how we're going to tackle the workplace.
Yes, it's a really good point, and I think we can cut the data in so many ways to kind of look at what's going on, and particularly by specialty, who are the main perpetrators of bullying by specialty, and does that vary? But I tried to do some of that initially, and there weren't any significant trends. Unfortunately, across the board, other SMOs were the main perpetrators, and that really didn't vary by specialty. But some of the other things, I might be able to drill down into it, but the problem is, of course, is that sometimes you just don't have the robustness of numbers because some of the numbers are small. But it's a really good point. Yep. I've got a question here, back in here.
Hi, I'm Jeremy Stevens. I'm an anaesthetist from Blenheim. Thanks very much for that presentation. It's pretty clear what we have to do. But I do think there is something which we ought to tackle underneath it all, which is fundamental. And it is a proper communication model underneath it all. A lot of this is actually signs of stress, having done the PCM course up to advanced level. And clearly these people don't know how to communicate. And it's a big problem throughout the whole establishment. It's a big problem in society, let alone here. And if we were to adopt a single-based communication model, which is across the board for everybody, I think you'd see a lot of this disappear.
Thanks, Jeremy. It's a really important point because I think it's actually the third paper in my reference list. It's called Sticks and Stones, and the point that the authors of that paper make is that while rude and dismissive behaviour can flourish in stressful conditions, it's not always the case. And there are some instances where people have either received good training or they've got really good interpersonal relationships with their peers, where even under the most pressure and stress, they don't resort to rude and dismissive behaviour. So I think that's a really good point. We could all probably learn how to give things like constructive feedback in a better way. I'm just thinking back to when I was lecturing at Otago, you actually had to learn how to critique and give feedback in a way that wouldn't be misconstrued. It's a real skill, and I think that probably is something that could be improved upon. Chris.
Yeah, hi, Chris Wisey, Otago. I'm a psychiatrist. I was just wanting to reflect on that systemic comment that the gentleman over there made. As a psychiatrist, I never fail to be astonished that I'll have someone with a whole variety of symptoms, anxiety, depression, sometimes post-traumatic stress disorder. And when I come to the educational history and I ask, were you bullied at school? So many people say, yes, that's basically what devastated their lives. And I'm seeing them sometimes decades down the track. And the impact of that is phenomenal, that annihilation of character. And I think we've got a massive systemic problem in this country. And that the cyberbullying has taken off and is completely out of control. You know, there are actual trolls out there who take a delight in trying to induce people to commit suicide. And I think it's the big black elephant in our system, and that it's excellent that your work and so on is reflecting us looking from the top. But in schools in this country, it's a massive problem, and that might be one of the most useful aspects of those nurses they think they're putting into schools, if they're just identifying that sort of behaviour to start with.
Yep, and there is a lot of work looking at bullying in the schooling system and so on and so forth, and so yeah, it's a huge issue.
Sorry to interject again, but I just wanted to also emphasise to the audience that in fact that to do a PCM course is one big model which is supposed to be interjected into the healthcare system in this country. It's been shown many places throughout the world in which it's been extremely useful. Air New Zealand, for example, has actually taken up on that model. It is well worth doing, not only for yourself, for your family, for everything as well. I mean, my wife, I encouraged her to, who's a chronic pain nurse, I encouraged her to go up to educator level in it as well. And she was the first one as a nurse to actually go that far, because of the cost. It's prohibitive, obviously. But to emphasise to the audience, I'm not necessarily a promoter of this. What I would like you to consider is that the PCM model is not just about communication, it's about it in every shape and form. It takes you all the way through the different non-verbal and verbal communication methods that we all do. And you can watch them in animals. I've watched them. I breed boxers, and you have to watch them. So it's there. We've just forgotten it. And it's recognising these patterns quickly and alleviating the problem before it actually spreads and becomes like this.
Yep.
John at the back.
Oh, there's one there with a mic already.
Okay. He's had his hand up for a long
Okay.
time.
I'm John McDonald. I'm a retired surgeon and I'm a bully. And if that sounds like the introduction to an AA meeting, then it's done for a purpose, because you very seldom hear the problem discussed from the bully's point of view. And I believe that AA does help a lot of alcoholics. I've got several friends who are alcoholics who have never had a drink for decades, and they do it. So look, I'm a bully because I get stressed in surgery, and I'm most bullying in the theatre. I've got a person who's been sitting right next to me who's a friend of mine who will vouch that I'm a bully and that he's been the recipient of it. And so have the nurses. I cope with stress in two ways in theatre. I sweated so much that if the nurses didn't wipe my brow, I'd drip in the wound, and that is a very demeaning task, I believe, for a nurse to have to do, but they had to do it. I also bullied them. And it was related to stress. I told them two things. One about the sweating. It's got nothing to do with the temperature of the room. It's how I perceive the operation going. They may think it's going fine, but if I perceive that there's a potential problem or a difficulty, I sweat it. And would they please do it? The second thing I used to tell them was, don't take anything personal. Now, I know that's a stupid thing to say, but at least it's an attempt to acknowledge. The third thing I used to say to them was, if you dish out shit, you have to take it. And Trevor, once again sitting next to me, will confirm the nurses used to give me hell at times. What I'm trying to get at is that the problem's complex. We have to look at it from both points of view. It is so bad overall that the bully is helped by his bullying in some ways internally, but it's very negative to the surrounding things. Is there a place for a type of AA type mechanism to be put in conjunction with other places to help it? I'd be interested to know. I suspect that there's a lot of other people in this room who could get up and say, I'm a bully too. How many of us are prepared to stand up, say it, and help from that point of view to try and solve the problem?
Robinson from Rotorua. I'm an anaesthetist. I think the common factor in the categories at the top there is the operating theatre environment. And there was a study in Canada by Villafranca and Jacobson, which was published in 2016, which demonstrated really high incidence of bullying in operating theatres. And then a quick plug, if anybody does want PCM courses, Lakes run them and I teach them.
Yeah. I just wanted to make one comment after John's thing. I was just interested in the way in which certain situations and perhaps the way in which we've been moulded by the system can encourage us to adopt these certain subject positions. And I was really struck in an interview I conducted recently with a female surgeon who said she really didn't want to act like the caricature of the female surgeon who dressed a certain way, spoke a certain way, and was bitchy. And yet, for 3 years in a row, her nursing staff had disregarded her preference list and had got her surgical implements wrong for 3 years. And each time she would say very politely, "Can you please fix this up and make sure you get it correctly next time?" And then one time, she just thought, sod this, and she just lost her rag, and she behaved like a bully. And she said to the charge nurse, "Why do you always do this to me? Why don't you get my male colleagues' implements wrong? I've never seen them get it wrong." And the response was, "Well, because they yell and scream at us." And she said, "Well, would you really like me to behave like a bully? Because I am quite close to that point." So I think that, in a way, shows how the system and some of the expectations and the caricatures and the norms have become so ingrained over time that you are quite actively encouraged to fulfill that kind of stereotype. Yeah.
Jeff Shaw from Canterbury. I am an intensivist. I actually have a brother who's a cardiothoracic surgeon, and we'll often have long conversations about various things. And he said to me once, he said, "I don't know of any other specialty or any other work in the world when you are constantly working at the limits of your ability." And I reflected on that for a while, and I thought, well, what do you mean by that? He said, well, 2 or 3 times a week, I am at the limits. And we know we're at the limits because we don't save everybody. We can't fix everyone up. And so I am reflecting on what John McDonald's saying, is that surgeons are a good example of a high degree of stress. But I would suspect that most of us in the room probably work at the limits of our ability from time to time. So I suspect that our work stress alone is very high, and that, at least in an intensive care environment, if you look at the PTSD in nurses, for example, it's about the same as you would expect of someone that's working in a MASH unit. We see revolting trauma and badness every day, people dying every other day. What was interesting is at Canterbury, on the list of bullying, the sort of prevalence, was actually in the lower tertile, or probably in the middle one. And yet we're supposed to have experienced this terrible earthquake and terrible stress. But I suspect the reason why, whereas Canterbury there, it's somewhere in the sort of towards a third of the way down towards the bottom. I suspect it's there and low because the earthquake stress is so small relative to the stresses in our usual lives. And I think that's a good comparative to some this research, some grounding, is that we do experience a lot of stress every day and we normalise it.
I think that's a really important point, Jeff, and I think the corollary of that is that we have to make it safe for people who are operating at the limits of their abilities to maybe say, actually, I could really do with some help here, or can you give me your opinion on this matter? As again, the surgeon who I was interviewing, she said it was really revelatory to her one day when one of her male colleagues came up to her and said, "Hey, I actually don't know what to do here. Can you help me?" And she was so shocked because this person was, as she put it, proceeding like the alpha male in the room who knew everything and had all the answers. But I think a lot of what's tied up with this, with the negative behaviours, the stress, the burnout and so forth, is perhaps that feeling that you cannot admit to perhaps not always knowing your stuff or that weakness.
I'm going to slowly start closing it down, so maybe last question.
Yeah, Roger Wanless from Invercargill. Is there a sort of character profile for the victims? Do they have a series of behavioural traits that we can identify and maybe deal with the problem in a slightly different way to enable them to fight back, if you like? Yeah.
There is research into the so-called personal characteristics of victims. But I actually find it quite problematic in a way, because I think in this situation it tends to put the emphasis on the victim as not perhaps being resilient enough. And again, you have that quote from that respondent saying, you know, we find it so hard to speak up because bullying is seen as a sign of weakness. So I know what you're getting at, Roger, but I think we also have to temper that by saying, well, would that in some ways continue to enable the problem? Yeah. Right, well, thanks very much. Really helpful.